Before we get started, I'll introduce our speakers for today. So first up, we have Dr. Alan Teoh, who is a respiratory and sleep physician at the Royal Prince Alfred Hospital, where he is involved at the ILD clinic. He also holds a postgraduate fellow position at Westmead Hospital and co-runs the ILD service there. And Alan is also undertaking a PhD at the University of Sydney and Royal Prince Alfred Hospital, where his research is focused on idiopathic pulmonary fibrosis, but includes other forms of ILD as well. Next up, we have Dr. Matthew Parker, who is a staff specialist in rheumatology at the Royal Prince Alfred Hospital in Sydney. He has a special clinical and research interest in autoimmune and related muscle diseases and in connective tissue disease associated interstitial lung disease. And we also are joined by a patient advocate today as well, Rossana Reyes. And Rossana has been living with diffuse scleroderma since 2019. And she works in revenue within health and enjoys spending time outdoors with her family. So we will kick off today's webinar with a presentation from Alan, followed by Matthew, and then we will hear some of Rosanna's lived experience with scleroderma as well. And afterwards, we will have our Q&A session, as mentioned earlier. So please feel free to submit any questions throughout the presentations for the panelists to answer. So I will hand over to you, Alan, to share your screen and start your presentation when you're ready.
All right, I hope everyone can see that. First of all, thank you very much to Lung Foundation Australia for the invitation to speak today. As Tara has already mentioned, I am a respiratory physician at RPA Hospital in Sydney, and I do have a special interest in interstitial lung disease, with one of them being systemic sclerosis or scleroderma, as we've already mentioned. So I'm going to be giving a talk more from a respiratory perspective, and obviously some people here would already know quite a lot of details about their own health with scleroderma, but I'm going to try to aim to keep this quite general for particular people who are new to the condition. So first of all, I don't have any disclosures relevant to this talk. And really a brief outline for the next 15 minutes. I'm just going to give a brief overview on scleroderma. I'm quite sure Dr. Parker will probably give a more in-depth review later on in his talk, but I'm going to also focus more from a respiratory physician's perspective on the management of scleroderma ILD. We're going to talk a little bit about the diagnostic processes and the challenges involved, as well as moving on to the broad overview of managing this condition. So for a lot of our audience here, they will be familiar with the term systemic sclerosis, or scleroderma would be the other terminology that we use. For those who don't, it is a chronic multi-system condition. It's usually characterized by widespread vessel dysfunction, so inflammation and dysfunction of the blood vessels, which can lead on to fibrosis involving the skin, as well as internal organs and joints. The thing about scleroderma is that it can present with various features at different time points, and one person with scleroderma may not necessarily be the same as the next person to them. It is a condition that affects females rather than males more often, but males do have this condition at the same time. There historically has been different phenotypes or different types of how the disease presents, such as limited or diffuse. But there are also sort of an overlap with these different features, which may come into play when it comes to their assessment with their physician or their GP. So a lot of, well, some of you may recognize some of these symptoms where you get thickening of the skin of the hands, which we call sclerodactyly. You have joint deformities due to the contraction of the skin over time. Moving on to the right picture, you do get these little spots that potentially can occur on the face, but can also occur on your fingertips, as well as in your tongue. We call them telangiectasia. And that just basically means that there's little dilatation or damage in the small tiny vessels under the skin. And I'm quite sure a lot of people would recognize the picture on the far top right, which is Raynaud's phenomenon, where there's a distinct change in the coloration of your fingers, particularly in relation to the colder weather, which we're going through now in Australia. So where we come in as respiratory physicians, as we know, and I mentioned already, that scleroderma is a multi-system disease that affects a lot of organs in your body. And we're going to focus more on the lungs today, but just a quick heads up that there will be also involvement of your heart. And I'm quite sure Matt would probably be talking about some of the other organs that may be involved with scleroderma. So just going down to basics in terms of what we know scleroderma can cause in the lungs is this terminology called interstitial lung disease. So some of you might be asking, what is interstitial lung disease? And basically, it's a condition affecting the interstitium of the lungs. And the interstitium of the lungs is basically the tissue or the fabric that holds your lung together. As you can see in the pictures there, if you bore down minutely into the lungs, your lungs are full of these sacs called alveoli that's led into them with a tiny little airway called bronchioles. And each alveoli sac contains multiple units where there's a lot of gas exchange that happens. So that's the main powerhouse of your lungs, where the gas, your lungs receive oxygen and gets rid of carbon dioxide when you breathe out. Surrounding this alveoli, there are lots of blood vessels that basically coat and surround your alveoli, and that's where the gas exchange happens. So where oxygen transfers through the interstitium, which is the fabric between the alveoli and the blood vessels, and the blood vessels will then offload the carbon dioxide levels, which your lungs will then breathe out. Now, if your interstitium, so I normally like to put this picture up as an analogy, your dishwashing sponge is full of air. It looks like the lung because it is full of air. It's like the holes in between, but there's a substance there that holds things together, and that's basically the interstitium. In interstitial lung disease, which may be associated with systemic sclerosis or scleroderma, the interstitium becomes a little bit thicker, and there may be reasons for that, including inflammation, but it can also lead on to fibrosis, scar tissue development. So from the picture on the right-hand side, you can see that the interstitium looks a little bit disorganized and thicker than the normal alveoli. And that impedes the transfer of gases, particularly getting enough oxygen into your bloodstream and removing the carbon dioxide from your body, which is potentially toxic. With a CT scan, for example, for those of you who have not seen a CT scan, this is a simple CT scan of your chest. What is black in the middle is actually good because your lungs are meant to be full of air. The white round portion there is your heart in between both lungs. There are tiny little spots and little lines that lead on within the lung itself. And that is, as best as we can see, what is meant to be looking like a normal interstitium. So it's hardly visible even on a CT scan. But you do get little blood vessels, you do get a little bit of the airways, you do get a little bit of the tissue within the lungs. When you have interstitial lung disease, unfortunately, this is what your lungs may look like, where instead of what you see as dark gray portions of your lung, it's filled up with little white bits in your lungs that are not meant to be there. And that could again reflect active inflammation in scleroderma or any immune-related ILD, or it could also boil down to scar tissue deposits in the interstitium that's not meant to be there. I have to put this slide up at the very start because it's important for everyone to understand that when we say interstitial lung disease, it does not equate to idiopathic pulmonary fibrosis. So if you were like any of my family members, if you were given a diagnosis, the first thing would be to rush into Dr. Google and we'll type in pulmonary fibrosis. And more often than not, idiopathic pulmonary fibrosis comes up as your #1 search finding as part of the algorithm. I have to stress that when you're told that you have interstitial lung disease, it does not mean that you have idiopathic pulmonary fibrosis. So it's two separate terminologies. ILD is more of an umbrella term compared to idiopathic pulmonary fibrosis, which is a very specific condition, which is not what we're here to discuss today. I put this slide up as a one-off because, as I mentioned to you, that we're going to focus on the lung disease. There are also conditions, well, scleroderma can also affect the heart, and you can potentially get this condition called pulmonary hypertension. What that means is that the blood pressure in part of your heart that leads into your lungs has a high blood pressure. And when that happens, the flow of blood leading into your lungs becomes even less, and it puts a lot of strain on the right side of your heart over time. The end result of that is that the same thing, you have less blood flow going into your lungs, and the blood's needed to pick up the oxygen level, pick up the oxygen molecules that your lung breathes in. So if you don't have enough of the trucks to deliver the oxygen, then you're also going to run into problems with low oxygen and symptoms from this condition. So in terms of symptoms, there are no specific symptoms from a lung perspective, but very often we do get people who are referred to us, not just from general practitioners, but also from specialist physicians, such as Dr. Parker as a rheumatologist, where their symptoms related to their joints and to their skin, but at the same time, they've noticed a few other little symptoms that have insidiously crept up over time. The most two common symptoms would be exertional breathlessness. So the first thing that people might notice is that the same distance that you would be able to walk about a year ago, you may not be able to walk that same distance without feeling breathless. As simple as that, without any other cause or reason as to why that could be happening. And that can potentially increase over time, and one person might vary from another. Coughing is another frequent symptom that people report, and it's usually what we describe as a dry, persistent chronic cough that lasts for weeks and lasts potentially even up for months, that doesn't go away. And it is a very disturbing symptom for a lot of our patients. As we are still reeling from the COVID pandemic, people have a lot of concerns about people coughing, and it is a huge challenge for people with interstitial lung disease. So I guess this is where we step in as lung physicians as to what we can do to help that process and that journey of yours to try to find out what's going on. And like I said before, very often we would have referrals from general practitioners, but we also would get referrals from immunologists and rheumatologists with the symptoms I've mentioned before. The first thing that we would normally do is to take a comprehensive medical history, understanding how long your symptoms have been around for, what severity it is, whether it's increasing in its severity, and how it impacts on your daily life, as well as your other medical conditions. We will normally listen to your lungs, as we all should do. And very often you might find that your lung specialist would say, oh, I hear some crackles. And that basically suggests to us that there's something in your lungs affecting the interstitium that's not meant to be there. So the crackles is basically like what you hear. It sounds almost like if you ruffle your hair between your two fingers, that's what we hear on the stethoscope. Beyond that, we would do a full panel of tests, which includes a CT scan of your chest to further characterize what we hear on your lungs. We will also order a full gamut of blood tests. Now, every center does things differently, but most centers or lung physicians would normally order what we call an autoimmune screen. And basically what that involves is taking a blood test, looking at all the different immune markers and antibodies in your bloodstream, some of which may light up, and that would be helpful in the diagnosis of what you have in terms of scleroderma ILD. Beyond that, one of the main things that we would be doing will be a lung function test, is the top right-hand corner. That involves you coming into a specialized lung laboratory, sitting in a chamber where the scientists would be doing a full breathing test on you, and there are different maneuvers that represent different portions and different structures of your lungs, and that will give us an overall picture of how impacted your lungs can be from the ILD. And the last thing at the bottom there would be an echocardiogram, because we talked about scleroderma potentially affecting the heart. Getting an echocardiogram gives us a very brief screening tool to see whether your heart is affected on top of the lungs. On top of that, which I didn't put, would be little tests such as a walking test, where we get you to walk to and fro on a corridor on a flat ground for 6 minutes. And what we do is we monitor your heart rate, when we monitor your symptoms along with your oxygen levels to see what happens on exercise. So what next? What do we do with all these information that we've collected over time? And the next step is very critical in all forms of ILD, where we basically bring all the information that we have into what we call a multidisciplinary meeting. Basically, it's a meeting where we sit down as respiratory physicians, and usually there are quite a number of us, and we would sit down with a radiologist, potentially a pathologist if there was any indication. And if we're lucky, like at RPA, we might have rheumatologists and immunologists such as Dr. Parker that will attend the meeting, where they can provide their expertise and their point of view. But the whole point of discussing your case at the MDT is to basically run through all the different portions or all the different tests that you had to try to come to a consensus among a specialist on what we think is going on. And the outcome that we want to hear is yes, whether you've got scleroderma, or no, whether you've got something else and we need to go down a different pathway. And in addition to that, it allows us to discuss what potential management options you have to offer these patients. A lot of our patients often ask, what could I expect for my condition? And the answer is not as easy, not as easily answered, particularly on a webinar like this, but it varies basically. So it depends on when we find the problem. And like I said, your symptoms may be very subtle, may be very insidious. So we might only find things out later on. And by that time, perhaps you might have a lot of you have a lot more fibrotic tissue compared to someone who's very early on to the piece. So again, this is a reinforcement to you that if you were noticing some symptoms that just doesn't add up, it's always a good idea to ask your specialist or ask your GP and talk about these symptoms so that the questions can be asked and further tests can be done to find out exactly what's happening with your lungs. Ultimately, the question that we have is, how is this all going to affect my management strategy? But there are lots of different things that feed into the management strategies. Firstly, we need to know what your condition has been behaving over 6 months, over the last 12 months. Has it been stable? Has it been progressive? Are you getting more symptoms? Or have you not really noticed any symptoms and you're wondering what your doctor's all concerned about? Other things also play a role, such as individual factors. And like I mentioned to you, scleroderma presents very differently from one person to the other. And likewise, different people would have different wishes. They might express things a little bit differently. They might have set ideas that they don't want to embark down treatment. I suppose age is also an important thing. A lot of young women get affected by scleroderma, so they're still in the working careers. They might still want to get pregnant. So there are lots of different individual factors that come into play when it comes to deciding what the best management strategy would be. And then when it comes to management with all medical conditions, you also need to weigh up the risk and benefits of starting management. So there are potential risks involved with each medication. And likewise, if you decide that, if your specialists are deciding that your lungs are actually quite stable and we monitor you closely, what are the risks involved? What are the benefits of monitoring rather than acting on your lung disease? So I like to think of management, and this is towards the end of my talk, the broad overview of management really boils down to, as mentioned, for predicting your disease behavior. So historical data with lung function tests and CT scans and symptoms will give us a rough indication of how your lung condition will progress over time. It's not 100% foolproof, but it sort of gives us an idea of how things are going to pan out in the next year and the next few years. Setting a goal or treatment is dependent on predicting these behavior. Are we trying to reverse the situation? So if you have a lot of inflammation in your lungs, maybe we could reverse some of that inflammation. Or are we looking more to stabilize your lung condition? Or are we heading towards the other end of the spectrum where we're just trying to slow down the condition from progressing further? The medications that are involved, again, highly varies from one individual to the other, partly because your lung condition would be very different from the person sitting next to you. But in a broad category side of things, it will involve some form of immunosuppressive therapy. And when we say immunosuppressive, which means that we give you medications to tune down or turn off your immune system so that it stops damaging your lungs. That could be simple things like prednisone, or that could be more advanced long-term treatments such as mycophenolate and rituximab. In more recent times, in the last 2 years or so, there has been a lot of talk about antifibrotic therapy, which are basically basically medications to slow down the buildup of fibrous tissue in your lungs that have historically been only available for other conditions. And as of last year, on the PBS, it's now approved for people with progressive lung disease, despite treatment that you've normally had. I put oxygen there because some people may have severe lung disease that require them to be on oxygen, and oxygen is a prescription medication that needs to be given by your physician, to decide whether you would benefit from it, or whether it might be better off to hold it off till later. And unfortunately, in some people, despite the medications that we give them, you might still have symptoms of breathlessness or cough that doesn't go away. And there are medications such as liquid morphine that you can take in small doses that helps with the breathlessness that you get. I have to stress a big component of the management is from what we call non-pharmacological approaches. Basically, it means any approach that involves not taking a tablet. And these are important because they have actually been shown to actually help people with their symptoms and help improve their quality of life. Pulmonary rehabilitation, which is basically a type of rehabilitation for your lung, is incredibly important and useful for patients that I've cared for. And it's pretty much available in most hospitals throughout Australia. It's important to pay attention to your nutrition because as you have a systemic disease, your appetite might start to falter over time, and nutrition is one thing that people often forget about. But even more important, I think, is having a support network, because living with this condition is not easy, and it can wreak havoc on your psyche if you don't look into this early rather than later. And I think it's incredibly important to have the right support of people around you to help with providing that psychological boost that you need as you journey through this condition. And for those of you who are smoking, it's incredibly important for you to stop smoking because smoking will continue to damage your lungs. And as I mentioned before, a lot of our patients are young, they're still working, they may or may not be interested to start a family. So those are the little factors that you also need to weigh up in terms of choosing the management strategy. And lastly, if we were to start you on medication, we need a way to monitor your response. And very often we would rely on the lung function, which is the breathing test I mentioned before, but we also look into potentially doing another CT scan down the track to reassess your situation, and that may lead on to medication changes if needed. Finally, I think it's incredibly, like I mentioned before, it's incredibly important to know who's on your team. And it's not just your GP, it's not just me as a respiratory physician, it's just not Dr. Parker as a rheumatologist, but it's basically everyone around you. It's incredibly important to build that relationship earlier rather than later. And we mentioned about nutrition, we mentioned about managing your psychology, we mentioned about symptoms. Now, the word palliative care, I put that there. A lot of people have a bad stigma about palliative care, but palliative care basically just means symptom management. and they're incredibly helpful when it comes to helping to manage your symptoms, and that could be cough, that could be breathlessness. They're really helpful, and I think it's important that people are aware of the help that they can get when they engage with these specialist medical professionals. And lastly, there are lots of support available. There is this current one on the Lung Foundation Australia website, which you can access to. As I mentioned before, it is basically pulmonary fibrosis as an umbrella term. It's not specific to idiopathic pulmonary fibrosis. It may not necessarily relate to your lung condition, and you probably should have a little chat with your physician about this first. I believe there is a potential booklet that might be coming up about scleroderma specifically, so that's something to look out for. But there are other resources on the Lung Foundation Australia, such as Peer Connect, which is basically allowing people to connect with peers all across Australia living with the same condition, so they can throw ideas off of each other and basically have a supportive family in a sense to guide you through the journey that you're going through. So I think I've gone a little bit over time, but I think that's all I'm going to talk about today. So thank you very much for your time.
Fantastic. Thank you, Alan. That was a really insightful presentation, and for providing that, respiratory specialist lens as well. That was really valuable. And like, as you mentioned, there is actually a resource on scleroderma that is new, and we have just published on our website. So that can be found on the Lung Foundation Australia website now. So we'll move on to Matthew's presentation, which will provide a rheumatologist's perspective. So I'll hand over to you, Matthew, to get started.
Thanks, Tara. Can you see the full screen there?
Yeah.
Yeah, great. So thanks very much. That was a great talk. I call you Alan, Dr. Teoh, close colleagues. So yeah, my name is Matt Parker. I'm a rheumatologist at RPA. Importantly, I'd also like to acknowledge my current research is supported by the Lung Foundation, and so Brian Eaton and his family, their very generous donation helps support my PhD work, but also I know the Lung Foundation supports so many other researchers that are working hard to try and improve outcomes in systemic sclerosis and related conditions. So that's something that's really important. I'm happy to talk to you today. It's great to see so many of you online, and hopefully there'll be others watching in their own time as well. Being an active part of your own treatment is really important. Sometimes you have to reach out for help as much as we want to give it. So this is about education, but also it's about hopefully breaking down some of those barriers and us working together as a team. I haven't spoken to this particular audience before, and I was grateful to Tara and Jamie just giving me a fairly good structure on the sorts of things that they thought you would like to hear about. We have the Q&A at the end, so if I've got it wrong, please make sure you ask us the questions you want to ask. But this sort of outlines what I'll cover just in 10 to 15 minutes. So there was aspects of other symptoms apart from the lung symptoms that Dr. Teoh has already covered, and then all these other questions here. Now, I'm not going to cover much of the lung-specific things because Dr. Teoh has done that in detail already, but hopefully I'll try and cover as much of the rest of it as possible going forward. And much of it actually will be on some of the other symptoms that you might experience or other changes related to systemic sclerosis that I thought were useful. Now, Dr. Teoh has introduced this. This is the sort of slide that I'll start most of my talks on systemic sclerosis about. I think it's important. I mean, firstly, we're dealing, as you all probably know, with an autoimmune condition that's rare, maybe 1 in 100,000 people. And it's this classic sort of triad of inflammation, vasculopathy, as in blood vessel problems, and fibrosis. And that combination of 3 different processes that can occur together can affect many different parts of the body, and that's what results in the symptoms you might experience or the things that we might find on tests. I'd like to stress now, and I'll stress again at the end, this is not a list of what you're going to get. Many patients never experience most of these symptoms or signs. It's very confronting when you start learning and reading about this condition, when you read about all these awful sounding different problems. But in reality, the vast majority of patients with systemic sclerosis have a really important condition that needs careful management, but not one that's going to shorten their lifespan, and not one that's going to put them in a situation where they can't cope and continue to do the things that they want to do or they enjoy to do. But in terms of covering the sorts of breadth of things that people could experience, I wanted to go into things in a bit of detail. Now, instead of covering things from a medical perspective, I've tried to put myself in the position, as I often try to do, but in the position of a patient or the carers of patients. So I'm going to make this quite practical, I think, about breaking down these different potential symptoms into things. I've labeled them as tips, but stuff that comes up commonly in practice that I've either found as useful or that people are asking me, and also maybe things that you might talk with your own doctors, the sorts of questions that I would want to be asked if you were my patient. So I might deal with these in turn. Firstly, Dr. Teoh introduced the idea of Raynaud's phenomena. So this is this symptom where your extremities, so especially fingers and toes, often triggered by cold, become either white, they change color white, sometimes then blue and red. Often an episode will last 10 to 20 minutes. In some people, it's not painful, but in many, it can become painful, especially in systemic sclerosis. And in about 50% of patients with systemic sclerosis, they develop what we call digital ulcers. And these are often exquisitely painful, and they form on the tips of the fingers, exactly where you'd be using your hands, and they are really unpleasant to experience. They're not themselves usually dangerous, although they're an important sign of something important underneath, but they're really substantial cause of potential impact upon your quality of life and what you need to do. So thinking about Raynaud's and digital ulcers is really important. I'd say almost all patients with systemic sclerosis will develop Raynaud's. Most of them have it early on, and but some don't develop it until other conditions have happened and it becomes more obvious. Usually, once patients have had the condition for 2 to 3 years, their Raynaud's doesn't usually get worse from there, but at any point it can be quite severe. So the things that matter most for Raynaud's and digital ulcers are in fact things that you can do, and prevention is so important because once you have an ulcer, it takes a long time to heal. So the things that are really important are wearing gloves, keeping your hands warm, but keeping your hands covered is also important. It's not just about being warm. So the trigger to Raynaud's is usually a change in ambient temperature. So that's obvious when you go from a warm environment into a cold one. Sometimes you don't think of it the other way around. In summer, walking into air-conditioned areas, swimming, so going from a hot summer's day into cool water. So all those can trigger an episode of Raynaud's, and you don't need to avoid those things, but wearing something over your hands, even thin gloves, even when swimming, for example, can make a big difference in preventing your Raynaud's being symptomatic. And think about your feet as well. So feet are just as vulnerable as hands. Using hand warmers, so a variety of these things exist, including gloves now that have built-in hand warmers, but they can be really useful as the weather's cooler at the moment. And also your environment, so where you can control it either at home, in the office, in other areas. If you can keep the temperature at a similar level in your environment, try and avoid sitting under ducted air conditioning so you don't have that flow of air, you'll find your Raynaud's tends to be a bit better. Another couple of things, so try to avoid things that would make your blood vessels constrict or vasoconstrict. So smoking is definitely something that triggers Raynaud's more commonly. But the other one I see quite commonly is beta blockers. So beta blockers are medicines used for blood pressure, but sometimes other cardiac problems. And beta blockers often cause your Raynaud's to be worse. Now, you may still need to take a beta blocker, but if you're on one and your Raynaud's is bad or you need to have one, then making sure the doctor prescribing it is aware of that link is important. I really want to stress a few things here, and one of them is if you develop a digital ulcer despite these things, you should get someone to see you straight away, that week, because the quicker we intervene, the shorter you'll have to experience it for. And it can be a really important sign of other things changing as well. There are medicines that we can use effectively, but some of the most effective ones you can only receive in hospital. Sometimes ulcers get infected and that doesn't help healing. And so there's a variety of things we can do if you have an ulcer. And the pain can be significant, but the best treatment for pain is actually getting blood supply back to that finger. It's not necessarily, although often we do use painkillers, but it's actually a sign that we need to do something different with therapy. And so just briefly, what should you ask your doctor maybe if this is a symptom that you experience? So I would ask the question, are there any medicines appropriate to try to reduce or prevent ulcers? Because there are many therapies that we can explore with you that can either improve or completely stop ulcers. on a general level, treatments are sometimes not successful or limited in their success, but they're always worth, I think, exploring if you haven't been there already. So there are some therapies that can help prevent these, which are important to consider. The next sort of symptom or topic Dr. Teoh touched on, it's a really important one. So in addition to interstitial lung disease, we have pulmonary hypertension. And if there was one thing you took away from today as a patient or a carer for someone with systemic sclerosis, if any new symptom of breathlessness or cough, you need to see someone straight away, because it's a really important symptom not to ignore. There's a variety of things that could cause it, but they're therapies that we want to institute promptly if one of these things was happening. Other symptoms that might imply pulmonary hypertension that you might not link include ankle swelling or swelling elsewhere, including sometimes people get fluid in their tummy, not in their legs. That's what we call ascites. So if you're having a tummy that seems to be a bit bigger than normal, then it's possible that that could reflect pulmonary hypertension, and we want to know about it. We can do tests to work out what the cause of that is. So questions you might ask your doctor if you were either had this or were worried about this. So especially if you're breathless, so I'd be very active at prompting, whether you need more tests. So pulmonary hypertension can be difficult to diagnose early, but it's so critical to do so. So Dr. Teoh talked about some respiratory function tests, echocardiograms. A quick shout out to, there's going to be a blood test that's PBS funded soon called BMP, which is a very convenient way to potentially screen for this complication. But really, if there's any even small suspicion of pulmonary hypertension, you're best seen at a centre where possible, where they have this particular expertise. Often that's a major hospital where you can have cardiologists, respiratory physicians, rheumatologists and others assess and then decide what to do with this condition. So it's a really important thing for us to try and pick up early. Moving on to the gastrointestinal tract. So actually, almost everyone with systemic sclerosis may have a symptom related to systemic sclerosis in their GI tract, and it can affect any part of the tract. Doctors and maybe yourselves are most aware of the involvement of the esophagus, so the food pipe, and especially acid heartburn, which is very common, although not universal, or problems with the muscles working, so problems with the swallow itself. People can get what's called dysphagia. But you can actually experience symptoms throughout. One of the underappreciated symptoms is actually large bowel involvement, so problems with constipation and sometimes even incontinence. We actually are less aware than we should be of patients who suffer with incontinence, and it might surprise you, but at least a third of patients with systemic sclerosis will have experienced an episode of incontinence. And it's something that we can help if we know about, but perhaps if you experience it, don't realize that it might be related. There's a variety of other things. There's things called small bowel overgrowth. There's other issues with the small bowel as well that can affect your nutrition, can result in things like diarrhea. Many of these things can be specifically intervened and helped with, but if you perhaps don't tell us about the symptoms, and if we're not good enough to ask about them, they can go untreated and causing significant symptoms for too long. People often ask me about diet, and we can talk about that later if you like. There isn't any specific evidence for a particular diet. There's many things you could do, for example, if you suffer from reflux, that might help with your symptoms of reflux. And then those other complications, if you experience them, there may be some more specific dietary interventions. But the main thing is to try and have a healthy diet and to make sure you're absorbing enough nutrients to keep you healthy. So questions you might ask your doctor. Almost everyone should be on, to us, there should be a reason not to be on acid suppressant medication with systemic sclerosis. And maybe you need more. We use high doses often. We use sometimes multiple treatments. If you're still experiencing reflux, we should be asking, is there anything else I should be taking? Should you be doing some more tests for the bowel symptoms I've got, my constipation or my diarrhea? And is there any evidence that maybe my nutrition is anything except perfect? Are there any tests that we should be doing and things that I should be doing myself? Onto, I guess, skin and bones and joints. So skin, scleroderma, means skin thickening. And so skin's a very common part to be involved. And often it's thickening from the distal or the extremities more proximally, so your hands and feet. Not everyone gets it, and it can be quite limited in some. And in terms of the joint involvement, arthritis is possible, but more commonly it's a combination of tendon, inflammation, joint inflammation and skin inflammation altogether that contribute to symptoms. It's usually fairly evident. I mean, on this hand here, some of the, this is the calcinosis here, the really white stuff, might not be that apparent to look at, but tests can show how extensive it is. And if anyone's, you imagine having this, which can be painful right on your thumb, like these things can be really significant, but we can do quite a lot to either prevent them or improve the situation. I think one thing I noticed, and especially from other patients that come, is that function can be difficult for doctors to assess. Like, we don't see you in your home environment. We don't know exactly what it is you want to do that you can't do. So talk to us and tell us those in that context, the sorts of things that you want to do that you're having trouble with, and that actually helps us understand what might be causing the symptoms. And the other point I'll make, and it comes across often when you have calcinosis like this, it can be tempting to try and fix it, cut it out, or extrude it. In fact, it often recurs more if you traumatize the area, so I wouldn't suggest that you do that. In the interest of time, a couple of things. Kidney involvement in systemic sclerosis may be in about 1 in 5 patients. It's relatively rare, but it's really important because it can be life-threatening and it needs urgent treatment. The picture down the bottom here, if you can see my cursor, is a blood vessel in the kidney that's become, we call it this onion skin. So it's like a skin of an onion that's gone around and squeezed that blood vessel down. It's a bit like Raynaud's, but in the kidney, and it causes, can cause kidney damage and even kidney failure. It's always accompanied by a higher blood pressure. And so one thing that I really stress for all my patients, but especially patients with diffuse systemic sclerosis who are more at risk of this, is that get to know your normal blood pressure. I would actually encourage you all to, if possible, buy a home blood pressure machine and to know what your normal is. Any increase in your blood pressure, like consistently over about 20 or 30 on the top number, the systolic number, should prompt you to ask your doctor if you need any assistance. And especially if that's combined with a headache, a persistent headache, I'd actually encourage you to go straight to medical attention straight away, and that might include the emergency department. And if you're really smart, it's going with this specific question: could this be my scleroderma causing a kidney problem? Because this is a rare presentation to the emergency department, and it's something they don't think about, but 24 or 48 hours can make a big difference in terms of the outcome. Treatment's very successful if we get there early. So things you might ask your doctor: so is my kidney function normal today, or has it been normal? And are you happy with my blood pressure? Might prompt them to think, oh, look, actually this has changed a bit, we should do some more tests. Pregnancy. So Dr. Teoh mentioned, many of my patients, this is predominantly more in women than men, about 3 to 1, and across the lifespan, but again, often in the 30s and 40s. So many of my patients are thinking about families and pregnancies, and this diagnosis can come at a very inopportune moment, and there can be these competing demands. So the message I want to get out is that it's actually very likely that with help you'll be able to have a successful pregnancy if that's what you wish. But there's lots of things we need to consider. There are some particular parts of systemic sclerosis that make it very dangerous for mum or for baby. So there are occasions where we would have a firm recommendation not to pursue a pregnancy, but that would only be if there was a life-threatening potential problem. But otherwise, we can help from everything in terms of getting you well for pregnancy, getting a team around you to make that successful, and then monitoring things through pregnancy. So, and I strongly recommend you have a pregnancy through a high-risk obstetric service that has some experience and interaction with the other specialists like rheumatologists and lung physicians. And so the pregnancy side of things is important, and there's a number of questions you'll be asking if that's your circumstance. And sorry, I'm keen to get through the content, but because Rossana's going to have some really interesting insight. The diagnosis of systemic sclerosis, so you've been through most of the lung stuff. What I'd say as well is that this is quite routine for your doctors. I certainly don't forget it, but you might get the sense that we don't appreciate how confronting it is. You've got a diagnosis that you've never heard of that sounds terrifying. Suddenly the doctor's sending you for all these different tests that seem like there's going to be something really serious going on. So that would be normal to feel confronted, and that would be stressful. We're often trying to prove that you don't have a problem as opposed to expecting to find a problem. But as I've said, I guess multiple times, finding a problem early in this condition makes a big difference to the outcome. So we look hard at the start, and we actually often will continue to look hard for these things. But you know, I hope you think we forget about how stressful that can be when you're waiting for results. I might move forward in the interest of time. How are rheumatologists involved? Well, it depends. Your team is unique to you, and you'll draw upon the resources you have available to you. It's not just about skill sets, it's about personalities, about people that you can lean on for different things as part of your management. But your team is likely to be large as you want it. And there'll be lots of non-medical allied health input as well. So dietitians, physios, psychologists, as Alan maybe talked upon in some patients. So we need to get a team around you, and then we can help you on that journey. Rheumatologists often, I guess, lead the specialty part, coordinating your care across different specialists and trying to keep an overview of everything. But we can talk about that later. I might whiz through this. Apart from, we often will do some tests regularly, like the tests for interstitial lung disease and pulmonary hypertension. You might be used to getting those. A really important question I get asked all the time, and you've got to really carefully consider it. What's my outcome look like? We are able to be much more specific with an individual patient once we get to know you. I do think that by and large, the most important factor in this is to realize that despite what you read and hear, most patients, as I said, with systemic sclerosis do not have a condition that's going to shorten their lifespan. And many patients out there are living relatively or completely normal lives with this condition managed well. So this is not a uniformly awful outcome, and we're here to help make sure that the outcome you get is as good as possible. So just to round up, there's lots of different things that systemic sclerosis can result in, but I would say most of you individually would rarely get many, if that makes sense. It's possible, but most people only get a few or even one or two of these things. And it's not a list of your destiny. It just might not happen. Being informed and active in your own care like you are today actually really helps me as your doctor keep you well. All symptoms can be managed. There's always things we can do to help. And many people can be there for the journey to help you in a variety of different ways. I'll stop there. Thanks.
Thank you so much, Matthew. That was a really comprehensive presentation. I really like how you integrated the questions to ask your doctor on each slide as well. I think that's got some really practical tips on there. So that recording will definitely be available for everyone if they wanted to refer back to those. So yeah, thanks again. I'll just remind our audience, if you did have any questions for any of the panelists around the presentations, please submit them in the Q&A box. We will answer them in our Q&A session shortly after Rossana's presentation. So yeah, now we get to hear the lived experience from Rossana. So just feel free to start whenever you're ready.
Sure, thanks Tara. And thank you to the Lung Foundation for allowing me to share my journey. So my journey began in 2019. I was 38 years old and considered myself a physically fit and healthy person. I was a jogger and I worked out regularly. I had very few health issues, but after a bad case of tonsillitis and pneumonia, a bit of stress, I did seem to recover from the fatigue and aches and pains of the flu. My initial symptoms were mostly around my hands. I had hand weakness, tingling in my fingers, my cuticles looked awful. I had a lot of fatigue, general muscle weakness, aching, stiff joints throughout the body. And at this point, I've had numerous GP visits. My GP suspected rheumatoid arthritis. I saw a rheumatologist who agreed and started prednisone treatment. However, over the following months, my condition continued to worsen and my hands and feet were so stiff, swollen, I was unable to walk. I needed help to do my everyday things, getting dressed and things like that. I had painful rubbing in my joints and it was just generally a very, very painful time of life. So I sought a second opinion, which I do encourage all new patients to do if they're not happy with their treatment at the time. And that led me to Dr. Matthew Parker, and he was able to identify very quickly the issue that I had with my hands and the changes in my nail folds was the microhemorrhaging, the painful rubbing in my joints. And by this time, my skin had started to thicken and tighten, and there was a clear diagnosis of diffuse systemic sclerosis. Over a very short matter of time, matter of just months, skin thickening and tightness had spread from my hands up to my arms, my chest, parts of my legs, quite a bit on my face. Sometimes it was happening overnight in my sleep. I'd wake up in the morning with severe neck and face tightening. Dr. Parker was able to start me on some medication that immediately started to make a big difference in my symptoms. The symptoms were now under control, and then he went on to refer me to other specialists to address other areas that were affected, gastroenterologists for some of the involvement I had with my esophagus, which is well controlled with some medication, but a lot with the lifestyle changes. So I guess changing the diet, drastic changes, because I come from a culture where we love everything hot and spicy. So had to say goodbye to that. Cardiologist for some benign cardiac changes that I had. Respiratory specialist for some mild lung involvement, which immunosuppressants are helping with. A team of physiotherapists who guide me through pulmonary rehabilitation that is also working wonders on my muscle strength. And these are specialists that I see on an annual basis, so do regular testing to monitor any changes in the disease. And all these issues happened in a time of my life where I was trying to start a family. With Dr. Parker's help, we were able to keep that dream alive. We were able to he was able to put me on medication that was safe for pregnancy, referred me to an obstetrician that could look after my pregnancy in the context of scleroderma. And the pregnancy, well, the first and second trimester were blissful. I entered some kind of state of remission. I remember feeling like $1 million, but at around 28 weeks, I needed to have an emergency C-section due to the high blood pressure and query renal crisis. My daughter weighed 994 grams when she was born, and she stayed in NICU for about 67 days, but she was medically healthy. She just needed to keep growing. And now she is a beautiful and affectionate little 2-year-old girl. So the remission continued right throughout. Well, I call it remission, feels like remission, but it continued right throughout until I finished breastfeeding. At that point, we changed the medication regime, and then I'm now on a mix of medications. We've lately found a good balance with prednisone and a couple of immunosuppressants. So that has been my journey. If I could give advice to someone newly diagnosed, I would say, develop open communication with your GP and all your specialists. Get to a place in your relationship where you can ask all the questions you have, come away from your appointment satisfied with the information they've given you. If you need to do additional research, look for legitimate organizations such as the Lung Foundation or Scleroderma Association. Be cautious about doing general Google searches and joining just scleroderma Facebook groups just willy-nilly. There can be a lot of doom and gloom in those places, and you really need to avoid your mind going into dark places because this kind of diagnosis is a lot to take in. Having said that, you have to find a good support network, seek professional help for your mental well-being when necessary. Something I probably should have done at the start, because you go through a whole spectrum of emotions. You don't always know how to navigate it all, and it's overwhelming. But if you have a good support network, your spouse, some family members, close friends. Personally, a question that sometimes comes up, I've chosen 2 or 3 of my family members who are my pillars. They understand the disease well. I keep them informed of my condition, my appointments, any new information. We've done research together, read articles together. I don't share so much information with my whole family or with all my friends. I've just chosen a few to be my pillars in this. Not everyone will have the same level of care or understanding, but that can be a good gauge for you to know how much information to share. if you don't know how to approach your family with this kind of, diagnosis. So it's been 3.5 years. 3.5 years ago when I was diagnosed, I thought my life was over. But I've been able to keep working. I've had my baby, tried my best to make the most of life opportunities despite the diagnosis. And that's really all you can do. I know everyone's experience will be different, but do your best. Life doesn't end at a diagnosis. You just need to make some alterations in your journey. And I hope that I shared a point or two that could be useful for someone who's facing this same journey. And thanks for having me.
Thanks so much, Rossana. Hearing your insights and experiences really helps bring to life the points mentioned by Matthew and Alan as well. So, I think that was really inspiring. So just in the interest of time, we are going to now move on to our Q&A session, but we will probably not have time to go through all of the questions. So I will just share my screen again. So now I'll move on quickly, and we'll try and get a couple questions answered. So the first question we have in today is, how can exercise or fitness assist my condition, and what are the benefits? Now, Matthew or Alan, did you want to maybe start on this one? And yeah, if there's any other points to mention, any other panels, feel free to share.
Yeah, I can weigh in on that. I think exercise, I suppose, with pulmonary rehabilitation, I think it's got a few benefits, particularly having a structured program where you get dedicated physiotherapists and nurses on what kind of exercises would be suitable for yourself. As Rossana mentioned in her talk, I think it does help with maintaining muscle strength. And the last thing you want to do, particularly if someone has a severe condition, and that could be anything from, interstitial lung disease or pulmonary hypertension, or even just really bad Raynaud's disease, is for you not to be active and do anything. And that actually is counterproductive. I've had a few people that come to me, well, I get breathless when I walk, so I won't walk. That is actually, like I said, it's counterproductive. It actually makes your life harder as time goes on because you lose that fitness that you get with keeping active. And having a rehab program allows you to do that in a structured process, where there's someone that's going to be guiding you specifically for your level of, I suppose, difficulty with breathlessness. They do take into consideration of your individual circumstances. So I think the structure is good. Having something routine or building something routine and regular in your lifestyle is also helpful. And all in all, I think if you don't get anything physical out of the rehab program, it allows you to pay attention to symptoms. They teach you what symptoms to look out for and how to deal with those symptoms. So that's my take on the exercise. It doesn't necessarily change the trajectory of your lung condition, but it certainly gives you that level of fitness to deal with the lung condition.
Yeah, and I would just briefly add, there's the confidence component, so it can give you confidence to get back into activity. And there's also a way of measuring your own progress. So it gives you insight to what you're able to achieve, hopefully feedback that you're actually able to do more. And for example, with Rosanna's experience, I was pleasantly surprised how much you got out of that, because you were already trying really hard to do exercise, but making some, having that input, I think made a big difference. Rossana, that was fantastic. Thank you for bravely sharing that story. It was really interesting to hear it. And I'm sure lots of others found it useful, just in case I didn't get a chance to say that. Thanks.
Thank you, Alan and Matthew. So we might just get time for one more question before we wrap up today. Now, one of the questions we got in was about Raynaud's, and the question was if there are any precautions someone with scleroderma can take to help prevent a severe case of Raynaud's from occurring
Yeah, no, I might jump back in there because the things I talked about are important, very important still. And when you've had an awful experience like that, they become even more important because you're obviously someone who is predisposed to those sort of severe attacks. So I'll be trying to tackle a whole range of things. A couple of things to mention: there are some medications that have been proven to help reduce digital ulcers, and including things like sildenafil, for example. And then there's also intravenous therapies that we use in an acute attack that can last for months afterwards. So we have got patients who have, severe Raynaud's who come in, in early autumn or early winter for almost like a preventative infusion. There, I suspect your team's already carefully thought about how to prevent it, but there's a whole range of things that we might explore to try and make sure that doesn't happen again.
Great, thank you, Matthew. So unfortunately, that is all we have time for today. We have run a little bit over, so we will wrap it up. But if there are any remaining questions, please do reach out to Lung Foundation Australia. I will just share our details on the next screen. So as you can see, we do have an information and support centre, so you can contact us on phone number or via email, both provided on the screen. On behalf of Lung Foundation Australia, though, thank you so much to our amazing panellists for sharing your experiences and insights with us today. We really appreciate you giving us your valuable time, and I myself have learned a lot today, and I'm sure a lot of people joining us today would share the same sentiments, so thank you. As I mentioned, you can also visit our website for information and resources around scleroderma and interstitial lung disease. So as mentioned earlier, there is a new fact sheet that has just been released on scleroderma, so that might be of interest to some of you today. And there are also some peer support options as well available. So please ring our information and support centre to find out how to connect in with others also living with your lung condition. So that brings us to the conclusion of today's webinar. Thank you everybody for joining us. We hope you found this webinar helpful in answering some of your key questions around scleroderma. But hope you have a lovely rest of your afternoon and take care of each other. Bye for now.